Goran, go right ahead. Thank you so much. Goran is a historic chair of the European Bifurcation Club, although he just decided after many decades to pass on the helm. He's chair emeritus now and full professor of cardiology, University of Belgrade. Go ahead.
Thank you. Thank you very much for the kind words. After 29 years, I'm back. So I was here in 1996 for 4 months, thanks to grant provided by Professor Kokinos. And we worked together. I have really one of the best memories of my life from those 4 months. And discussing the caliper-based measurement and TIMI frame counting from your patients. By the way, I identified patients in Greek database without knowing a single Greek word at that time. So I spent the whole night identifying patients. Then Professor Kokinos says, this is right, this is wrong, this is wrong. And I worked on the population. We published that in Circulation, and that significantly impacted on my life because I got fellowship in from Onasio. I got a 3-year fellowship with Antonio Colombo in Milan. I worked very hard with him, and then I joined immediately European Bifurcation Club, and I was president for 10 years. I just decided to focus now on some different aspects, on teaching and working with fellows. So I think this is a fantastic period of 4 months which completely shaped my whole career. State of the art in bifurcation PCI, these are my conflicts of interest. I start with mentioning intracoronary imaging guidance for left main and bifurcation PCI as class 1 indication in the European guidelines, but also this year in acute coronary syndrome guidance in United States. So it's clear that use of imaging, especially for left main PCI, is something that significantly improves clinical outcome. The major contributor to that is the October trial, 1,200 patients randomized to image guidance by OCT versus angiography guidance, and it showed clear 30% reduction after 2 years of follow-up. What is a little bit unexpected for us is that benefit was observed mainly in provisional stenting, not in 2 stenting techniques, but the results were diluted by crossover to IVUS guidance in left main PCI group. In total, more than 15% of patients which should have undergo angiography guidance actually had IVUS guidance versus OCT guidance. If we look contemporary bifurcation subgroup analysis, Occupy October, Illumian 4, and the Renovate, you can see that we were a little bit surprised because if you see bifurcation guidance outside of the left main does not get better clinical outcome in any of these trials with image guidance compared to angiography guidance. Only if we dig deeper and we look specifically for left main in Occupy and Renovate, it's a benefit of imaging for left main PCI. And as I mentioned in the October, there was no difference, but 50% of patients were IVUS guided. So in order to put all this data in the perspective, European Bifurcation Club and European Association of Percutaneous Coronary Intervention, EAPCI, currently work together on the document on the role of intracoronary imaging for left main PCI. I'm the senior author in this paper, and this is EBC board, scientific documents group, and also a large group of international experts. Document is almost ready. It's under revision currently, and I hope we will have it published very soon. Very briefly, we believe that in both provisional and 2-stent approaches, we should use the imaging to define landing zones with plaque burden less than 50%, to determine stent platform that we will use, of course, determine stent length considering necessary extension for proximal optimization, stent selection, plaque morphology. If we do plaque modification preparation, then we have to repeat imaging. And finally, imaging can be used to determine the strategy upfront provisional versus 2-stent strategy. But at the time when we had 2023 European Bifurcation Club meeting, we discussed the October data, and this is the protocol for the October. So very detailed description how to use imaging. If you try to find one single sentence how to perform optimally angio-guided procedure, actually there is not a single word. So they leave it up to the operator discretion. And for that reason, we published this 18th consensus document trying to emphasize how to optimally perform angiography-guided bifurcation PCI if imaging is not available. But of course, it means that we need to be even more focused on careful planning and meticulous performance of bifurcation PCI if we don't have imaging, and we should not complete procedure without any doubt regarding the optimal result that we achieve. Consensus has 3 sections, before, during, and after PCI, and we extensively discussed for the first time non-invasive imaging and the role of procedural planning based on non-invasive evaluation with CT and FFR angio in order to plan procedures, select the strategy, type of the device, etc. During PCI, we stick to our MEDS classification, promote provisional stepwise or double kissing crush as side branch stenting first, but for every step, systematic application of technical steps is really important for the selected technique. We don't try to influence decision regarding stenting technique, but if you select, for example, provisional, then you really need to go through these 5 steps and carefully evaluate the result at each step. Most of the procedures with provisional guidance can be finished after main vessel stenting and proximal optimization, more than 90% of cases. But if you don't achieve good result, you just evaluate, and after POT, if you have significant diseases, the ostium of the side branch, you exchange the wires, you do the kissing with or without the POT, and then you again stop, evaluate the result. If you need second stent, you put second stent as part of the provisional using T-tap or culotte stenting. And that's the reason why, as EBC, we promote philosophy of provisional stenting, which means you don't need to decide up front if you need 1 or 2 stents. You just increase complexity, you go through the steps, and if you need second stent, you put second stent. If you use side branch stenting first, like double kissing crush, it means that you will never finish procedure with single stent. If you start provisional, in 75 to 90% of cases, depending on lesion type and patient complexity, you can finish procedure with less metal with single optimal stenting of the main vessel only. The key for understanding is actually this OCT fly-through from Leuven, in which you see that coronary vessels don't taper linearly. Actually, at every major bifurcation point, you have step down in diameter. Step down is determined by the natural fractal law, which tells you that larger side branches will result in larger step down. This is circumflex, this is now ostium of the LAD. And this is the key for selecting the stent type and stent platform. We can reliably measure, if we don't have imaging, we can use dedicated QCA software, and we can reliably measure all 3 segments, proximal and distal main vessel and side branch diameter, because we need dedicated software because reference diameter is not a linear function, and we need to separately calculate main vessel and the side branch. We learned from Patrick Seruyu's group, from Dr. Kubo, that OCT really precisely determines diameters very similarly to phantom model, but if you use IVUS for evaluation, IVUS overestimates measured diameters by 5 to 10% depending on the vessel size, and if you use QCA, QCA underestimates by approximately 5%. So what you measure by QCA is actually 5% smaller than natural fractal diameter. Knowing that, you need to also know the device that you have on your shelf. And this is the maximum overexpansion capacity of currently available drug-eluting stent platforms, which means that every stent has 1, 2, or 3 platforms. If you select large vessel platform from any of the currently available DES, you can expand it to approximately 6 millimeters, which should be sufficient for most left main reference diameters. And you see here that Zions and Ultimaster can go to 6.5. Do we always follow the rule and select the stent according to distal main vessel diameter? We try to understand in case of large discrepancy, and that's frequent question in everyday life. If you have distal vessel of 3 millimeters and proximal 4.5, should you use according to distal 3 millimeter stent platform? If you do that, you see that after post-dilatation, you have severe deformation of the stent in the polygon of confluence. So for such large discrepancies, based on imaging, we suggest to select one size larger platform, deploy it at low nominal pressure, and then post-dilate with appropriately sized proximal main vessel pot balloon. And you see that you have much better coverage of the polygon of confluence and much less stent deformation and drug delivery. Another important aspect is proximal optimization. Should you always start from the distal main vessel, from the carina side, or you should go, like in this case in bench, you can also do it from proximal, especially for ostial left main PCI. If you do it from proximal left main, you see that actually you don't have stent elongation and you achieve very similar stent expansion in the proximal main vessel like you have it in the bench, and you see optimal expansion without stent elongation. These are just bench testing data, so we recommend to test this. We don't have clinical outcome data, but I recently had a patient with large plaque burden in the left main, and I planned to start from the ostium proximal optimization, but I was worried that a large shape of the balloon after first initial inflation will not allow me to go distal. So we should really think of the patient population in which this could be applied. During proximal optimization, pot puff sign was described as injection of just 1 or 2 cc's of contrast. And you see that if your size of the balloon for pot is adequate, actually there is no flow distal in the main vessel. So very simple sign to measure if the size of the pot balloon is optimal or not. And we can also, if we don't use intracoronary imaging, we can use stent enhancement tools at every stage during and after the procedure. And you see here that with stent enhancement, you can really see malapposition, malexpansion, and stent deformation. And we can use stent enhancement to improve it, and this is just OCT confirmation of this stent deformation at the proximal stent edge. Balloons are also semi-compliant or compliant, so if you inflate more than once, you achieve reference vessel and reference diameter of the balloon at much lower pressure. So if you inflate the first time, you need much higher pressure compared to repeat second or third inflation. Keep this in mind and try to inflate balloon at least 2 or 3 times, even for a shorter period of time. And then if patient tolerates, then keep balloon inflated for 25 or 30 seconds, because that's the only way to really achieve expected vessel diameter. Finally, I just want to show you a case example in which we apply all these steps. This is a young lady, anterior STEMI, borderline hemodynamics, ostial LAD is definitely the culprit. So the strategy is to do dedicated QCA to assess the diameter of the left main and the circumflex. And this is thanks to our board member, Yanis Chatsizisis. We work with him to have a dedicated site on the internet to calculate a diameter of the third branch when we know 2 branches. So as I said, by QCA you measure 4.1, 3.5, but because of underestimation of diameter you need to increase by 5%. So true diameter of the left main is 4.4, and true diameter of the circ is actually 375. Then you go to this online calculator, to EBC website, and you put two measured diameters, and this is Dr. Chatzizis's work, so you can find easily, precisely that size of the LAD proximal is approximately 3 millimeters. If you follow the rules of EBC, you upsize by one stent platform larger, so we took 3.5 millimeter balloon. We use, of course, in this case, crossover stenting towards the LAD from the left main. We expand with 4.5 balloon inside the left main, and we stop at this point, and this is OCT just as a confirmation that you follow the rules. For optimal angiography guidance, you actually achieve similar result like image guidance. Not in all cases, but for example, in this case, we have LAD's MSA of 8 square millimeters and 14 millimeters inside the left main. So, dear colleagues, I would like to conclude that EBC supports the use of imaging for left main and complex bifurcation PCI. Optimal result, full stent expansion in the position, should ensure good clinical outcome, regardless it's achieved by angiography or intracoronary imaging guidance. Key points for achieving optimal angiography-guided PCI is thorough analysis of pre-PCI images, CTA, multiple angiographic views, dedicated QCA, vessel estimation, systematic application of technical steps for each selected technique, intra-procedural or PCI use of stent enhancement software, and very low threshold if you have intracoronary imaging for bailout use of intracoronary imaging. Thank you very much for your attention.